modified. For example, a patient who has got a collagen disorder, and a patient who has uh, uh, any drugs which is taking required to control his or her comorbids are some of the things which you might consider modifiable and non-modifiable. Some of the commonest risk factors that weakens the tissue are the smoking. With the respect to age, the tissue gets weak, the tensile strength goes down. Then the patient who are on steroids, immunosuppressive medications, collagen disorders. Okay, you want me to repeat the last slide? Okay. We have just started off with the definition that hernia is basically protrusion of a viscous or a part of viscous through a defect in a wall containing cavity. I'll show you a diagram in due course of time, so that would help you understand this question well. So we were talking about, okay, what factors are there that could lead to the formation or enlargement or the recurrence of a hernia. So either they are related to weakening of the tissue, or they are causing the increased tension on the tissue. So patients who are smoking, who have got a higher age, on steroids, immunosuppressive medications, they have collagen disorders, they have surgical wounds, patients who have undergone, who are pregnant or who had been pregnant, undescended testes, obesity. They are all the risk factors that would, by and large, would somehow increase the intra-abdominal pressure and the pressure on the wound itself. So they are likely to cause the hernia formation. However, there are other risk factors. For example, if a patient is lifting up heavy weights, so patient is obese, indirect constipation, patient is coughing and having a difficulty urination or has bladder outflow obstruction, these are all the risk factors that can uh, cause a patient to develop the hernia. Now, now look at what the hernia is. We talked about hernia as an entity which has uh, viscous and a part of viscous along with its covering. So in this case, the viscous will be the small bowel loops, okay? And the part of the viscous would be the content of the small bowel loop, and the covering will be formed by the peritoneum lining, which is the hernial sac. So in this picture, one can appreciate that the patient has the hernia composed of a sac, the covering, and it has got its own contents. The point of strangulation and where the complication arises is the neck portion of the neck. That's where the problem started. We were discussing how it translates clinically. So the sac has got a neck body and the fundus. And when we talk about the sac of the hernia, it's basically a diverticulum of the peritoneum. The peritoneum is a smooth lining the internal cavity of the abdominal wall. But when there is a potential defect, the peritoneum outpouches from the defect side and forms a diverticulum. So it has got a mouth, the neck, and the body, and through which the hernial contents protrudes out. The layers of the abdominal wall through which the sac passes will comprise what are the layers. For example, a hernial defect which is passing through the anterior abdominal wall would have the covering of the entire layers of the anterior abdominal wall, which is another example of a hernia. A hernial defect which is passing through the lateral wall will have all the layers of the lateral abdominal. So the content can be an omentum, In that case, it's called nomentocele. If it's an intestine, it's called an enterocele. You could have in a hernia an ovary, tubes, portion of the small intestine, a rectus hernia, Meckel's diverticulum, which is called the Litter's hernia, and you might have an appendix, which is called a Medell's hernia, which might be there in the. So whenever we talk about complications, a hernia can become an irreducible, it can become obstructed, it can become inflamed and strangulated. All these things are related to two major issues. One is the either the bowel is obstructed or not, and the second is the compromise of the vascularity. If the only obstruction is taking place, that means the bowel contents cannot be reduced, but the supply is not compromised. So you have an obstructed hernia. But at the very same time, if you have a hernia which is in a defect, and because of by virtue of the additions cannot be reduced back into its normal cavity, so it's incarcerated. Inflammation process starts whenever there are signs of ischemia. So the early there would be signs of inflammation, which would then lead to strangulation and then formation of the gangrene of the bowel. So this is how the hernia will go for it. Irreducible hernias are if those hernias and contents cannot be reduced back into the abdomen because of the adhesion or the large content and the narrow neck. Then the neck is exactly the same portion which we discussed earlier, in which I showed you the diagram. Hernial contents, they usually balloons over the external ring when reduction is attempted. So there are likely chances of being uh, patient getting repeated damage at the side of the neck whenever manual reduction is attempted. So at some of the authorities would not advise manual reduction of the uh, hernia if it is either strangulated or obstructed, because it can cause further damage while reducing it. An obstructed hernia is basically an irreducible hernia with obstructed intestinal lumen without interference of the blood supply. This is exactly what I said earlier in my statement. But clinically, they can present with colic, constipation, or vomiting. These are all symptoms of a mechanical bowel obstruction. Sometimes it's difficult to differentiate from strangulation, so it's better to be managed at strangulation hernia. We had one of the examples, like we said, inflamed hernia. So if you have an obstructed hernia or an inflamed hernia, and if you are unable to differentiate it, so it's better to manage them in lines of strangulation rather than managing them as a case of an obstructed or an inflamed hernia, because you would likely to save the life of a patient rather than create further morbidity and mortality. Strangulated hernia, it's a hernia when the blood supply of the patient has been compromised. So this pressure or the hernial contents, especially veins, low pressure, they are very sensitive venous congestion, and they get uh, further edematous and becomes irreducible. So it is a cyclical thing. The more venous congestion is there, the more bowel tends to get obstructed and further supply is reduced. First, the venous system gets occluded and then followed by arteria. And then what happens, because the gut contains the microbial flora, there is transmigration of the bacteria. So all the area gets inflamed, secondly infected, and there is gangrene and perforation. So when there is serious impairment of blood supply without obstruction, it can lead to ischemia, and if not treated within 5 to 6 hours, leads to gangrene. So whenever a patient comes to the ER, or even some patients can land with a strangulated hernia in the OPD, one needs to seriously consider if it's a strangulated hernia or not, and urgent preparation for the OT should be done. At times, there is no the bowel is not part of the hernial sac, so you have strangulation without obstruction. So you could have a dead bowel, dead omentum, The ovaries could have been strangulated within the hernia. You could have rectus hernia in which the part is there and there is also rectus hernia. So what are the clinical features of strangulated hernia? There is pain. There are signs of obstruction. That means the patient has got abdominal pain, distension, vomiting. There is irreducibility. There is no cuff impulse. The site of the hernia is tense and tender, and if not treated, it may lead to ischemia and gangrene, and patient could lead up into septic shock. Inflamed hernia, in which there is sign from the local bowel as well, or from the underlying structure that is being inflamed. So the source of inflammation could be an appendix. It could be from the skin, from the ulceration. Clinical features as that of inflammation are usually they are there is pain, there is redness, there is hot tenderness, but it's not tense. If it is tense, then you might need to consider a diagnosis of a strangulated hernia. So the commonest hernia you would encounter in your clinical practices are the inguinal hernia. They can be direct, they can be indirect. So just a recap of the inguinal canal, if you've gone through your earlier years of your MBBS, is basically an oblique canal. It extends from the deep ring and exits out from the superficial ring. It is about 4 centimeter in adults and infant. Both rings are opposite to one another. So in uh, in infants, it's more or less aligned in the same direction. But as the adult grows, this ring from straight becomes an oblique pathway. So there are more chances of an adult hernia getting obstructed than in the infants because by virtue of the straight. However, in children, it can also present with the same challenge. Um, in male and female, by virtue of their gender, you could have different contents within the hernial because most of the hernias we are talking about inguinal are in the inguinal region. So it would tend to take with it the organs related to the genitals. And in male, you would have spermatic cord with all its content, and ilioinguinal nerve, genital branch of the genitofemoral nerve, and arteries to vast difference. In testicular artery, mastoid artery might be compromised whenever you have an inguinal hernia. In female, however, there is round ligament, ilioinguinal nerve, and genital branch of the genital nerve, which are present as a part of an inguinal hernia. The commonest hernia, as I mentioned, are the inguinal hernias, and there are femoral hernias, and there are scrotal hernias, which have a complete descent from the groin region. And then you have umbilical hernia, which we'll discuss later on, incisional, ventral, or epigastric hernia. Recurrent hernias are also there. There is hernia formation at the site of the stoma, and there is hiatal hernia, which is a rare type, congenital diaphragmatic, Spigelian, operated, and lumbar hernias. These are all rare type. You would see them in your clinical practice, but not very often. So just another way to look at it, the groin hernias usually are either inguinals or femoral. So the inguinal, you have an indirect type, a direct type, or a combined, which is called a pantaloon um, hernia type. And then the anterior abdominal walls, you have umbilical hernias, paraumbilical, epigastric, and Spigelian hernia. From the posterior abdominal wall, so even the posterior wall is not spared. So if a patient comes with a swelling, thoroughly examine it because a patient could have a hernia at the back also. So the patient could have a superior lumbar hernia and inferior lumbar hernia. And then pelvic hernias are there, in which a patient could have obturator hernia, sciatic gluteal hernia, and there are incision hernias, and there are internal hernias as well. Internal hernias, one would mean the patient there's an internal defect. A defect could be within the mesentery window. It could be through the broad ligament, or it could be a defect surgically created in which the bowel knuckle gets obstructed. So these are the also variants of the hernias present. So based on the incidence, the commonest hernias one would have are the umbilical, paraumbilical, inguinal, and femoral, while Spigelian, obturator, and superior and inferior lumbar and gluteal sciatica are the rare sites of the hernia. Now, if you look at this example, uh, there is gross disparity between the right and left side of the patient. On the right side, the patient has an enlarged swelling, which is extending from the groin and reaching up to the level of the scrotum. However, where from the left side, one cannot be that much appreciated. So this patient has got a right-sided complete inguinal scrotal hernia. This is another example of the patient with an inguinal hernia. There, in the first picture, the patient has a small inguinal hernia. On the other hand, you could see hernia on the right side of the patient as well. So these are another two pictures depicting an inguinal hernia. Femoral hernias are mostly common in females, but by and large, inguinal hernias remain common in females as well. So in femoral hernias, the hernia protrudes through the femoral canal in the femoral triangle, and it appears in the thigh and the groin. So if you see the relationship um, as compared to previous picture, this is the inguinal crease on the left side. So the patient would have a hernia formation which is below and lateral to the inguinal ligament. So if that's a femoral hernia. So if you have above and medial, so that is the inguinal hernia, and if you have below and lateral, that is the femoral hernia. So, uh, femoral hernias at times are very nasty because they mimic many of the groin swellings. There are lymph nodes there, there is fat there, sometimes there are lipoma present. So it creates a challenge. So many of the patients with femoral hernia, they present with signs of strangulation. So an early surgical is being warranted. We have just a recap. Anterior abdominal wall hernias. The commonest is beside inguinal hernias, we have epigastric, paraumbilical, umbilical, and Spigelian hernia. True umbilical hernias, they usually are in adults or patients with ascites or patients who have developed because of the pregnancies. So the defect goes through directly through the umbilicus. Okay, as you can see in this picture, there's a defect in the just with the umbilicus. And there are paraumbilical hernia. Paraumbilical hernia, they tend to form a crescentric presentation. So one would have a hernia which is more of crescentric, and these are usually acquired hernias. Increased cuffing, abdominal straining, weightlifting, they tend to get. Paraumbilical is by and large far more common in females than in male because of the childbirth and pregnancy. ठीक है ना? So a paraumbilical hernia, the hernial orifice is at the site of the umbilical scar, so that the sac bulges out beside the umbilicus. That is the main discriminating point. It doesn't go through the umbilicus, but it bulges outside. That is why it is called a crescentic shaped slit. These are the subclassification of the paraumbilical hernia. If it is, it can be supraumbilical as well as the infraumbilical. So if you just look at this picture, okay, what do you see? Which type of hernia is this? Can you answer me in the chat box, please? Anyone else? What others think of it? Good. So it appears to be basically a supraumbilical, or what is being described as a ventral or a epigastric hernia. Now you can see very clearly in this. This lacy was misdiagnosed as a lipoma for many years. The swelling site is over here. And this was the another picture. Okay. Now coming on to the Spigelian hernia, you must have heard about the arcuate lines, right? These are the um, congenital intersection that where the sheaths combine and they provide strength to the anterior abdominal wall. So what happens if there is a hernia where which forms at the lateral border of the arcuate line? Is called the Spigelian hernia. So the Spigelian hernia is not very common, but you might come across one or two patients in your lifetime of the Spigelian hernia. So you see these are the landmarks, the umbilicus. The hernia is far on the lateral side of the rectus. Okay, we're talking about posterior wall hernias. So basically, posterior wall has got lumbar hernias. The back is being provided by muscles which are latissimus dorsi, rectus spinae, serratus posterior, internal oblique. They form a grid of muscles, and when there is a defect, the hernia tends to protrude with it. These hernias are very common in patients who have got a lumbar surgery being done, especially for procedures for renal stone nephrectomy. They tend to have a lateral or a lumbar hernia formation because the incision, the muscles get weak, so the content tends to get protruded from it. This is another example, incisional hernia of a patient who has got a nephrectomy done. So incisional hernias, by and large, are hernias which occur through the acquired scar, and the scar stretches progressively if the patient has a constant stress. These constant stress are coughing, straining, infection, and patient has gained weight. So all of these things would tend to leave uh, uh, cause the scar formation. So mostly they occur in obese individuals, patients who has got post-op abdominal distension, post-op infection, hematoma. There may be history of factors like weaken of the abdominal vasculation, chronic cough, steroid therapy, or at times the weakness is often unnoticed, and the patient would have intact sutures in place, but the wall stretches slowly and progressively. Then, in a few months' time after the initial surgery, the patient would come with swelling over the operative site. So, patient would have an incision hernia. This is one of the pictures. A patient who had an expansile cuff, and this patient probably would had a laparotomy done for some abdominal thing. So now he has developed a large incisional hernia, which is defect. At times, incisional hernia large enough to accommodate almost half or two-thirds of the entire abdominal cavity. So these are the very nasty hernias to repair and to manage in the long run. There is one more entity which is known as the divarication of recti. In the divarication of recti, it is important to understand that the patient usually presents with an abdominal swelling. But all abdominal swelling which have got a cuff impulse does not mean that they have got a hernia, because of the muscles get separated from the midline, as you can see in both in this picture. So the wall is weak. So whenever the patient stands or patient cuffs, one would appreciate a swelling being visible. So this is not a hernia, it's the divarication, which would require either some sort of cosmetic surgery, plication, or if they or patient could be advised weight reduction and use of abdominal belt. Okay. In children, there is divertication in the first few years, and the condition gradually improves as the child grows. So I mentioned concern is usually cosmetic is there, and there's disfigurement, and strangulation is not possible because there is no neck of the hernia. Okay, the entire wall bulges out. So uh, the patient needs to be counseled accordingly regarding the problem. And then we have got a rectus hernia, which occurs at the anti-mesenteric bowel hernia through a facial defect. Mesenteric side is the basically uh, through which the blood supply is coming, and anti-mesenteric side is opposite. So when a portion of the bowel gets involved, okay, so that's what the